things that we have no intention, we do not intend to impede PAs anyway, other than some very invasive things that they ask our opinion about. And that's our opinion. We do not think that some of these things should be done without the doctor there. Because we get to the other end of the stick. We get the doctor in Montana, and the mid-level provider is stuck in wherever, and they call us and they complain and say, my doctor is in Montana, honey, what am I supposed to do? And we get those things. So don't think we're against PAs, we're not. We realize that PAs have a very valuable part in providing health care in Louisiana. So thank you for coming.
That wasn't a question.
Well, that wasn't right.
Thank you, Doctor. Appreciate it.
Dr. Mitchell Litzman is the next speaker.
Good morning. Thank you for the opportunity to discuss. My name is Dr. Mitchell Litzman. I'm a practicing cardiovascular surgeon in Lafayette, Louisiana. This is going to be repetitive, I am sorry, but a lot of people have a lot at stake, and a lot of good practice is at stake. We are absolutely committed to quality care and efficiency of care. Physician assistants are highly trained and highly proctored after they come out of their training, more so than registered nurses, more so than nurse practitioners. Many of the procedures listed in this act are now done by LPNs and registered nurses. Just by a physician's order, such as removing an arterial line, removing a central line. I can write the order and an LPN or an RN can pull that art line. It's not a big deal. Another example, as has just been mentioned, my partner and I are cardiac surgeons. We have 2 heart rooms. We try and operate every day. I tell my patients I operate on any day that ends in Y. But if we have 2 cases going, chest open, heart stop, patient cooled, and on the other end of the hall, a patient in our ICU develops a tension pneumothorax, I can't break. I can continue my operation with one of the surgical techs assisting to a degree. But I have to send my physician assistant to put a chest tube in. And we have been told point blank by our hospital administration that if I'm not there looking at the physician assistant standing at the bedside while the chest tube is put in, that physician assistant has to stand there and do nothing, which in the case of a surgical emergency, that patient will die. And I understand your comment about emergencies and such, but this has to be delineated. With all due respect, the comment about a physician being in Montana, I think is 1/100th of a percent of an occurrence, and no physician, certainly in our specialty, would ever instruct a physician assistant to perform procedures when he or she is not readily available. If we are to be more efficient, our presence at the bedside for these procedures, such as listed numbers 1, 2, 3, and 4, removal or placement of an arterial line, removal or placement of a Swan-Ganz catheter, an arterial catheter, or a chest tube, removing an arterial, an intra-aortic balloon pump, and as Dr. Ventura testified, even placing a balloon pump is a waste of our valuable time so that I can be more efficient in caring for our patients. If I have to be there, I'll do the procedure myself. But if the physician assistant can extend my ability to render care, that by definition is quality and efficiency. We're not going to send a physician assistant in to do something that is beyond their capability. Our practice in Lafayette has employed physician assistants since 1996, and we have enjoyed the top of the state's of the state and national rankings year in and year out. We are committed to quality, and we're committed to efficiency, and physician assistants help us do that. Thank you for the opportunity.
Thank you.
Thank you, Dr. Lisman. Our next speaker is Robert Benson. Dr. Benson. This is, let me just take a moment. This is the last card that I have. One more. If there's anyone else who would like to address the board after these next two speakers, please fill out a card and give it to Ms. Arsenault.
Thank you. Unlike many who've spoken today, I have a rural, semi-rural dermatology practice, see large numbers of patients, and do take seriously the fact that the state has put forth hundreds of thousands of dollars to train me. And I've always tried to fulfill that mission of taking care of these patients in Louisiana. 2 or 3 years ago, I became aware that despite the fact that I'm close to the I-12 corridor and we have enough patients within a reasonable proximity to fulfill the needs of the practice and make it work. I was by myself at this time. Medicaid patients were not seen by any board-certified dermatologist all the way from beyond Slidell to Baton Rouge and all the way up to Jackson, Mississippi, Hattiesburg, Mississippi. Occasionally Tulane residents are at Lally Kemp, but I think that has fizzled since Katrina. Since employing 2 nurse practitioners and 2 physician's assistants, rather than me limiting my Medicaid patients to 4 to 6 a day, which I had to do because of the reimbursement schedules and just for practical reasons, now we see 40 to 50 Medicaid patients per day, and we take all comers, and it's just these people's ability to allow us, in the face of the healthcare system changes that are coming, where they're going to be a greater expansion of Medicare, plus the increased documentation that's required, even in spite of the EMR, with government and insurance third-party payers, just takes a lot of time to see patients. And these people that work for me who are highly skilled, they allow us to do what we should do, I think, as healthcare providers, and that is provide the best care we can to as many people as possible. Secondly, as has been, I'd like to second what's been said several times, the skill level of these people in dermatology. In my experience, the 2 PAs far exceeds, when it comes to procedures, the nurse practitioners. There's no contest at all. And dermatologists do more procedures probably than any other specialty there is. We do things to everybody, and these people, and they're not overriding procedures that have a great amount of risk. In the initial list that came out, I believe on this list were biopsies, and thankfully now I see biopsies of an internal organ has been qualified. I would implore the board to take into consideration superficial surgeries within the skin versus invasive surgeries through the skin into the internal realms. I would just like to thank you for hearing us, and to please consider that as these changes in the medical system come about and we have to see and care for more and more patients, these people are just unbelievably essential to us providing quality of care.
Thank you.
Doc, we don't intend to do anything that would impede your practice.
Our next speaker is Lena Osborne, PA.
Good morning. Thank you for the opportunity to be here and to speak to y'all this morning. I am Lena Osborne. I'm a physician assistant. I graduated the PA program at LSU in 2000, so I've been out here for a while. I currently am the academic coordinator for the physician assistant program at Our Lady of the Lake College, as well as the president-elect of LAPA. After listening to the comments that the board has made in regards to the issue of section 4507C3, and we just wanted to make you aware that even though you're saying that that's not the intention of the board as to the level of supervision and services that may be delegated are subject to board advice and guidance concerning the levels of supervision or services identified in that section on its website, that's just what it reads. So that's why we have taken that as one of our major tasks this